All right, welcome to your Rapid Fire BCOps Explainer. We're skipping the basic anatomy today to deliver a high-yield study session on the exact clinical pearls you need to know for CNS tumors and central nervous system involvement. Look, if you're a chemotherapy-trained pharmacist gearing up for the board exam, you already know the basic mechanisms of action. So today, we're laser-focused on the strict parameters, the lethal black box warnings, and the targeted genomic therapies that are virtually guaranteed to show up on your test. Let's get started. Here's our high-yield CNS study checklist. We're going to run through CNS prophylaxis and safety protocols, the PCV regimen for gliomas, the absolute essentials of glioblastoma multiforme, primary CNS lymphoma interventions, and wrap up with targeted therapies for IDH mutations.
Section 1. CNS prophylaxis and safety protocols.
So picture this. You get a patient profile requiring CNS prophylaxis. Your board exam is absolutely going to test your knowledge of intrathecal administration parameters, and more importantly, the fatal errors associated with them. The goal here is simple, right? We want to maximize drug concentration in the cerebrospinal fluid, where that volume of distribution is smaller and the half-life is longer, while keeping systemic toxicity as low as possible. But what's the critical safety check you need to make?
You need to lock this in for patient safety. While drugs like methotrexate and cytarabine are perfectly safe and compatible with cerebrospinal fluid, giving any vinca alkaloid intrathecally is universally fatal. I mean, it is an absolute non-negotiable contraindication. If a case study tries to slip a syringe of vincristine anywhere near a lumbar puncture tray, you flag it immediately. No exceptions.
Now, what about patients who don't get intrathecal therapy? Well, protocols often use high-dose systemic methotrexate or high-dose systemic cytarabine instead. Why? Because at these massive doses, they reliably cross the blood-brain barrier. You'll also see corticosteroids thrown in there as supportive care, and that's not just to help kill cancer cells. It's actually crucial to prevent chemical arachnoiditis. That's a really severe inflammatory complication you've got to watch out for.
Moving on to Section 2. Gliomas and the PCV regimen.
Okay, imagine you're taking the test and you get a simulated case about a young 35-year-old patient starting the PCV regimen post-radiation. You can't just recognize the acronym. You need to know exactly which drugs are oral, which are IV, and on what specific days they're given. The execution is everything here.
So here's the exact breakdown you need to memorize. Procarbazine, that's oral, days 8 through 21. Lomustine, or CCNU, is also oral, but only on day 1. Then you have vincristine, which is intravenous, given on days 8 and 29. This entire block repeats every 8 weeks for up to 6 cycles. The test makers love the specific mix of oral and IV days, so definitely expect a multiple choice question on it.
And here is your crucial clinical pearl for this section: 2 milligrams. When you're verifying that PCV regimen, your IV vincristine dose has got to be aggressively capped at exactly 2 milligrams. It doesn't matter what the patient's body surface area is, this cap is there to prevent severe, totally irreversible neurotoxicity. So literally never verify a dose over 2 milligrams.
All right, Section 3, glioblastoma multiforme or GBM essentials.
GBM makes up a massive 54% of all gliomas. It's the most common primary malignant brain tumor in adults. Now, when you're reviewing a GBM case, keep in mind that for immunocompetent patients, surgery is strictly limited to biopsy. On top of that, whole brain radiotherapy just isn't considered sufficient on its own anymore. The rates of severe neurotoxicity are just too high, especially if the patient is over 60. So you're almost always going to be looking at a combined modality approach.
Now, the board exam won't just ask you to pick a generic regimen for a GBM patient. Oh, no. They are going to give you a detailed patient profile, complete with lab values and performance scores, and ask if the patient even qualifies for methotrexate-based induction chemotherapy in the first place.
So here are the exact cutoffs you need to know straight from the guidelines. You only consider induction chemotherapy if the patient's Karnofsky performance status, or KPS, is firmly greater than 40. Second, their creatinine clearance has to be strictly above 50 milliliters per minute. If a case study throws you a patient with a CRCL of 45, methotrexate-based induction is completely off the table. Keep those two numbers right in your back pocket.
Let's shift into Section 4, primary CNS lymphoma interventions.
This particular disease state has a very distinct sequence. A highly tested initial and consolidation sequence includes rituximab, methotrexate, procarbazine, and vincristine. After that, you'll typically see a consolidation phase using reduced-dose whole-brain radiotherapy paired with cytarabine.
Understanding the specific phased approach is absolutely key when you're evaluating a complete treatment plan.
But here's the tricky part. What happens when the primary CNS lymphoma is refractory or the patient relapses, and you've got to select a targeted salvage therapy? Well, the actual biology of the tumor shifts, and that reveals a brand new vulnerability.
You've got to remember that relapse disease unmasks a really critical role for Bruton tyrosine kinase. And because of that, ibrutinib becomes a highly effective monotherapy or combination agent in this refractory setting. If BTK inhibition isn't the chosen route, you definitely need to recognize pemetrexed or the combination of pomalidomide and dexamethasone as valid guideline-supported salvage options too.
And finally, Section 5, Targeted Therapies and IDH Mutations.
You know, in oncology, seeing a mutation on a chart is rarely good news. But this is the big exception. When you spot an IDH1 or IDH2 mutation on a pathology report, you should instantly recognize it as a positive prognostic indicator. It actually predicts a longer overall survival, and more specifically, it indicates a highly favorable response to temozolomide in patients with low-grade gliomas.
When it comes to targeted oral therapies, you need to be able to match the drug to the specific mutation in the disease state perfectly. You match ivosidenib specifically to IDH1-mutated advanced gliomas. Vorasidenib, on the other hand, is a bit unique because it targets both IDH1 and IDH2 mutations, but its indication is strictly for low-grade gliomas. Don't let the exam trick you into swapping those two indications around.
As we wrap up this explainer, I want you to ask yourself one final question. Can you confidently navigate these strict parameters and lethal black box warnings on the fly? Are you going to be able to keep the PCV dosing days straight and those IDH mutation targets totally clear? Because I promise you, mastering these fine clinical distinctions, knowing exactly when to intervene and when to verify, is exactly how you pass the BCOP and provide the highest level of care to your patients. Keep studying, stay focused, and trust your clinical knowledge. You've got this.